Um, Thank you for coming, and I hope that you're not being forced to come here. So, I bring greetings from my team. This is a team of the doctors which we have at our hospital. It's a GI, it's a basically comprehensive GI and GI cancer surgery department. So, the talk I have decided, the title I have decided for this presentation is the other half. The reason behind why I titled it the other half, there are two reasons. One is that when I do a surgery, patient recovers and goes home, so I get the credit, right? But actually when I do a surgery, it's a half job done. The half of the recovery is because of my staff, the physiotherapist in my team, the dietitian in my team, and the other members of the team. So it's not the surgery which gives the recovery, which is responsible for the recovery of the whole. It's a lot of efforts put in by the other members of the team is also important, including physiotherapists, right? And I'll tell you very honestly that some of the major surgeries which we do, probably physiotherapists are the deciding factors between the life and death of the patient. So that is the reason why I said that it's a other half. The second reason is that when we get trained into the medical college and when we learn about the anatomy, the physiology, the biochemistry, at the end of the training we feel that we are the king, but when we actually come into the practice, it's a completely different thing, right? What we learn in medical college is 50%, rest 50% you have to start learning when you start your private practice. So in my presentations I am going to talk about some of the GI surgeries and how physiotherapy is important in GI surgery, and I will also put some of the things in the perspectives so that you will be little ready to understand that when you finish your degree, what you are going up to and what you are going to do in the future, what struggle you are going to make, and how you are going to navigate in your future for a better outcome. So I am sure that the physiotherapy faculties would be teaching so much that I might not be teaching you a significant thing. I am not going to teach you some hi-fi things. I am just going to give you a simple idea about GI surgery, about the role of physiotherapy, and how to navigate your life out of your degree. That is my purpose, to provoke some thought process rather than teaching you a full and pure academics. When I was making the presentations, I talked to some of the physiotherapist colleagues, and I came to know that some of the students in physiotherapy or even the practicing physiotherapists, they feel that they are not into the physiotherapy by choice but by situations. They want something else they didn't get and they come into the physiotherapy. I am sure this thought process would be resonating you with some of you, if not all of you. And many of the physiotherapists also feel that this is an under-recognized and under-appreciated field. And many of the physiotherapists they change their profession after completing the degree. So let me tell you, so keep this thought in your mind. I will come back to this. I will go to the GI surgery first and then I will come back to this thought again. So I am sure you must be learning anatomy during your training. So this is a liver, this is a esophagus, that's a stomach, that's a small intestine, that's a pancreas, that's a head and body tail of pancreas. Now pancreatic surgery is one of the most, it's considered one of the highest category of surgery in GI and GI cancer surgery. When there is a tumor in the head of the pancreas, we remove the head of the pancreas, the part of the duodenum, part of the stomach, part of the bile duct, this whole thing comes out. What remains inside is the part of the pancreas. And then we have to re-anastomose, rejoin the whole 4 structures which we have opened. The bile duct is open, the stomach is open, the pancreas is open, the intestine is open. We have to rejoin all these 4 structures so that again the physiology functions in a normal way. It takes around 6 hours of the surgery. We are pioneer to bring this kind of surgeries in the city, not only doing it occasionally but doing it routinely with an outcome which is at par with any institution in the world. Now this is a case, a young female with a large mass into the head of pancreas. This is a tumor, this is the rest of the pancreas. So we have to remove this tumor. This is the same patient, the operative picture. To perform this surgery, it takes this kind of incision. This is called a J incision or a reverse L incision. The incision is given by a Japanese surgeon called Makuchi, so it is also known as a Makuchi's incision. Now why it is important, right? For a physiotherapist, after an abdominal surgery, knowing about the surgery and incision is very important. This incision starts at the xiphi sternum, comes up to the umbilicus and then goes on the right. Very big incision. After this surgery, because of the pain, because of the upper abdominal incisions, patient will not be taking a deep breathing and patient will have some or other problems. Here comes the role of the physiotherapist. Now what can go wrong with this patient, right? I do a surgery, as I said, it is just a half job. Rest of the half job is to be done by a physiotherapist and dietitians and the staff. So because of the pain, this patient will subconsciously not take the deep breathing. The lungs will not inflate, the lower zone of the lung will not inflate well, and they will develop atelectasis and pneumonia and consolidation, and this patient can die even if the surgery is done well, right. So these are the x-rays. If you do not get a good physiotherapy and good mobilization after surgery, the things can go wrong and patient can die. So physiotherapists have actually very important contributions in a recovery of a patient after any major surgery. Now again another patient, a young female with a similar lesion in the tail of pancreas. Now we do many of the surgeries laparoscopically. So this is a small video of a laparoscopic surgery where we remove the distal part of the pancreas. So I will just explain the anatomy. This is the stomach being retracted up, the colon has gone down. This is something known as lesser sac, that is a pancreas, that is a spleen, that is a left lobe of liver. Now as you saw the big incision, this surgery is done with a small 2 or 3 small half centimeter, 1 centimeter incisions over the abdominal wall, no any major incision. What we are clipping is a splenic artery. So what we are going to do is we are going to remove the distal pancreas and the spleen together. Right. So we are clipping the splenic artery, we have already clipped the splenic artery, this is a splenic vein. Once you clip the splenic artery and splenic vein, the surgery becomes safer. Right. So first you control the blood supply and then you dissect the tumor. That is the principle of any GI cancer surgery or any major surgery. So the artery and vein are clipped, that is a pancreas, there is a tumor there. So now we are mobilizing the pancreas, we will divide the pancreas from here, and the tumor, distal pancreas and the spleen will come out, right. So that is the pancreas being lifted, that is a stapler that will staple as well as the cut the pancreas. You can see the pancreas is being divided from the middle, and then you separate the rest of the pancreas and the tumor from the rest of the attachments, and that completes the surgery. So now in these situations, this patient, if we have to do an open surgery, this patient will have something like L-shaped incision, right. But here you see 1, 2 and 3 only incisions. This is a financial incision from where we will bring out the tumor. So there are few advantages, right. It is a cosmetic advantage. A female patient wearing a sari, there will be no problem, there will be only small incisions. This area will be covered under the cloth. Because there is no upper incision, upper abdominal incision, there will be less pain. This patient will be ready to move on the next day morning. Even after 6 hours of the surgery, patient will be walking around. But laparoscopic surgery does not mean that everything is completely safe. You need to know the detail of the surgery also. Because you remove the spleen, the left upper abdomen is empty. So the movement of the left diaphragm will get hampered. If you do not do a good physiotherapy in this patient will have a left lower zone consolidation. patient will have fever, patient will need an oxygen, patient will need an ICU stay. So even if it's a laparoscopic surgery, we need to see. So that is, it is very important that you just don't think about the physiotherapy, think about the patient as a whole, the disease, the surgery, the incision, what is the requirement of the patient is very important, right. Now this is a patient which has a tumor in the center of the pancreas, right, and we will remove the center of the pancreas. So this is the whole pancreas, this is the duodenum, this is the tumor, we remove the center of the pancreas. Now this tumor was adherent to the one of the major vessels which we call a portal vein. So while we were removing the tumor, there was a major bleed, almost 1000 ml of blood loss happened. We did a lot of blood transfusion to this patient, finished the surgery, stabilized the patient, patient went to the ICU. Now this patient needs this kind of incision, this is called a bilateral subcostal incision, right. It is also known as a bucket handle incision because the shape looks like a bucket handle. Now this patient also can go into the chest complications because it is a upper abdominal large incision, but there is something different also here we have to think, because patient had a multiple blood transfusions, there can be some other complications. There is something known as TRALI, there is something known as transfusion associated lung injury. If you do a lot of blood transfusions, there will be an immune reactions between the antibody antigen of the donor and the patient, and this patient can end up into this kind of lung shadows which acts like a consolidation, but it is a different. So now the management of this is a ventilator and supportive management, but the moment patient is out of the ventilator, the role of physiotherapy starts, because this patient again goes into the same vicious cycle and the complications. So physiotherapy is very important in this patient. Now this is the same patient. If you look at the patient, this patient has an endotracheal tube in the mouth, and patient is sitting on the chair, right. So we are about to remove the ventilator from this patient, but before that we gave the trial of movement, trial of sitting on the chair, and we confirmed that we can remove this patient in endotracheal tube safely. Now if you do not see this, you will not be able to imagine that the patient on a ventilator with an endotracheal tube can sit on the chair. It is possible, right. Most of the transplant surgery, most of the major surgeries, next day morning patient normally sits on the chair, right. So this patient, the ICU team, the physiotherapist, the nursing staff has to put on a lot of efforts to bring this patient out of the problem. So patient has to be walking around, sitting around, doing a lot of spirometry, lot of chest physiotherapy, and only then this kind of patient can come out. So blood transfusion can create a problem, less movement can create a problem, no deep breathing can create a problem. Everything has to be kept in mind by a physiotherapist. It is not just a theoretical or a routine stuff. Every patient is different and we have to treat every patient differently. Now this patient is ready to discharge. Even after 1000 ml of blood loss, even after staying on the ventilator for long, even after lung complications, not because of the surgery or not because of the meat, because of the supportive staff, the physiotherapist, the ICU staff. So that is how the important role of physiotherapist is, right. We brought the liver surgery in the city. Before 2013 when we started practicing in Vadodara, all the liver and pancreatic surgery patients used to go to Mumbai and Delhi. We started these surgeries in the Vadodara, and now all patients are being treated in Vadodara. Any surgery, gastro or gastro cancer surgery which can be done anywhere in the world can be done in Vadodara now. So this is an operative picture, this is a whole liver, right. This is a falciform ligament, this is the right lobe of liver which has a large tumor, right. So we cut the liver here. Now liver is a vascular organ. 90% of our liver surgeries, they do not need a blood transfusion. So this is the divided liver, the half of the liver is out, the left lobe is inside the patient's body, and this is a tumor which is out, right. Now this surgery is normally done open with a big incision, but we started doing this surgery laparoscopically also. So this is one of the video, you can see a large tumor in the liver, that is a gallbladder, right lobe of the liver, and that is a tumor, and we are operating with a laparoscopy. Again small phalangeal incision, lower abdomen, and the tumor can come out. The difference between the upper abdominal incision and lower abdominal incision is massive. A lower abdominal incision patient can go home next day, the upper abdominal incision patient will have to stay in the hospital for 5 days, 7 days. So that is the difference. So this is how we divide the liver. There are special equipment, there are special techniques. You apply a clips to the vessels and gradually divide the liver. As I said, more than 90-95% of our liver transfusion, the liver surgeries, they don't require any blood transfusion. So all this kind of complicated surgeries happening in the Vadodara, and all this kind of complicated surgeries needs supportive staff, needs physiotherapists, needs rehabilitation, and that is where the role of the physiotherapist comes. So never underestimate your profession. There are a lot of roles, lot of gaps in the market. You have to fill that gap, and you will be more successful, right? So that is how it completes the surgery, and then a small incision, and that tumor can come out without any major incision, right? That completes the surgery. You can see hardly any major blood loss. Now there are different incisions. So now this liver surgery, if I have to do open, I need this kind of incision, the bilateral subcostal and then the midline extension. This is known as a Mercedes-Benz incision because it looks like a Mercedes-Benz the logo, right? This is the financial incision which is routinely used for a cesarean section, right? This is an L incision or J incision, reverse L incision. This is a bilateral subcostal incision. This is a midline incision. So different incisions, upper incisions more pain, needs some more rehabilitations, the lower abdominal incisions, the less pain, early recovery. So what incisions a patient has is also important, you need to know that, right? Now many people think that laparoscopic surgery, they may not need a physiotherapy or they will recover fast, but that is not true, right? So this is a case of, so I operated this patient for CA colon around 10 years ago. This patient came back with an hernia, this is called an incisional hernia, right? You can see the center of the abdomen is weak and it is bulging on cuffing. Now hernia, I am sure you must be knowing about hernia, but I will just give you a brief. So briefly, the abdominal wall has a muscles, fat and skin. When there is a gap into the muscle layer, that area is weak, you cough and there will be bulging because the omentum or the intestine which is there, which is freely mobile, will come into that gap and will look a will give a bulging. That is what we call an hernia. So now we have done this surgery laparoscopically. This is a small clip of that patient. You can see a lot of adhesions because of the previous surgery. This patient already had a hernia surgery somewhere else for 2 or 3 times before. So we remove the adhesions, whatever has gone into that gap defect, we bring them down and then we repair the gap. So these are all contents which are going into the gap, and so what we are seeing from below, it's an anterior abdominal wall from inside, right? So you can appreciate the gap, right? So there are multiple gaps, the wide gap, the 2 edges of the rectus muscles have gone far away from each other, and that is the reason it's a weakness in the abdominal wall. So now once you do everything, once you reduce all the contents, you have to stitch the defect, stitch the edges of the muscles together. Again doing it laparoscopically, very difficult. Now this patient had a 10 years before surgery, so both muscles were not coming closer to each other. So what we are doing is we are mobilizing both edges of the muscles so that they can come little closer. Huge amount of dissection. From outside you will see only 2 or 3 or 4 incisions, but inside the abdomen we are doing a huge amount of dissection. So once you do the dissection, you will have to stitch both the edges of the muscles together. These muscles are 7-8 centimeters away from each other. You are tightly suturing it together. This muscle suturing will give the patient a lot of tightness in the abdominal wall, and patient will again not take the deep breathing. Even if it's a laparoscopic surgery, patient has a lot of pain, significant tightness. So as I said, every patient is different. If you know the disease, if you know the problem, you will find out what is the solution. So individualization is the key. So you can see now we are suturing it, right? So we are bringing both the edges together. So now when we are tightening it, the abdominal muscle wall is getting tightened too significantly, right? So this is going to be a tough time for the patient after surgery. So this is what we need to know. Even if you are a physiotherapist, this is what we need to know, that what has gone inside, what has been done inside, and that is how we will be able to treat the patient better, right. Now once you suture it, because it is a weak area, the risk of recurrence is also very high. So what we do, we put a mass, it is an artificial mass which will support the abdominal wall. So this is a mass, right. This mass will get fixed to the abdominal wall, this will give a strength to the muscle wall. Now when you fix this muscle with, there is something known as stacker, there are screw like things which will fix the muscles to the anterior abdominal wall. These are piercing the muscles, this also gives a lot of pain. So this patient will have a pain even significantly higher than the open surgery. The only advantage here is that we are not cutting it, so we are not making the abdominal wall further weaker. So that is an advantage, but pain is not an advantage here, right. So this patient also needs a lot of physiotherapy, lot of movement, lot of encouragement, right. Now this patient, because of the pain, was not mobilized for 24-48 hours, and next day morning your surgeon will tell you do a physiotherapy for this patient and you will start patient walking, but that is not correct. You have to see the patients, you have to see the vitals, you have to examine the patients and decide it. Now this patient has a pulse rate of 140, saturation is low, something is going wrong. If you make this patient walk, this patient may die, right. So examining the patient is very important. If you examine further, one patient's lower limb is swollen and it is a raid. If you press the calf, patient has a tenderness. So this is a deep vein thrombosis. Because patient has not been mobilized for 24-48 hours, this is a problem, right. Now acute DVT, you can't mobilize the patient immediately. You give him heparin, stabilize the patient and then start mobilizing it. So seeing all these things is very important. If you mobilize this patient immediately on a 85-84 saturation, this patient can die. So all these practical things we need to know from the patient, from the training, from the experience, right. Now another underappreciated thing about the physiotherapy in GI surgery or any abdominal surgery is the peristalsis, the bowel movement. Once we do an abdominal surgery, once we touch the bowel, the peristalsis movement of the bowel goes down. It returns back on second, third, fourth, fifth day. It depends on how patient is active and how patient is actively mobilized. So you mobilize the patient well, the patient bowel movements also comes well, patient goes home also well. So that is also an important role of the physiotherapy, right. This patient can go back home early, this patient can go back to work early just because of difference in the physiotherapy, right. So what is the ideal time to mobilize the patient? So there is no ideal time, we have to individualize patient, right. It can be on the same day, on day 1 also, but generally for any major surgery not later than day 1. So in our institute our protocol is that so we consider day of surgery as a day 0, very important to learn. Post op day 1 is the next day, right. So day 0 we ask the patient to have a leg movements in the bed. If it is a laparoscopic surgery and patient comfortable, patient will be sitting in the bed, there will be leg dangling, patient is sitting on the edge of the bed, everything is possible. But leg movement is possible in every patient on the same day, and next day morning patient has to be out of the bed and patient has to be doing a spirometry. These are the compulsory. Next day morning I am on the round, all my patients are either sitting or walking or doing a spirometry. If I am not seeing that, that is a difficult time for the staff and everybody, right. Day 2 you increase the mobilization, increase the spirometry, and by 3 patient has to be fully mobile. But as I said, individualization is the key. One very important thing most of the people miss is the pain, right. Most of the people, most of the surgeons, they do not give adequate painkillers. It is very important to understand that for first 1, 2 or 3 days patient has to be pain free even after surgery, and if patient is pain free, patient will walk well and that will help the recovery. So individualization is the key, right. Now next morning my all patients, either they are sitting in the chair doing a spirometry or walking around. It is a fixed rule, right, except there is a specific reason no patient is in the bed on the next morning. It is a fixed rule. Now there are some practical problems. Those who are intern or those who are visiting the hospitals, probably they might have experienced, right. If you go to the ward or ICU as a physiotherapist, nobody cares, nobody responds, right? The staff, the doctors, the patient's relatives, they don't respond you well, right? You need to be a little talkative, you need to be a little communicative, you need to know how to start the conversations to the difficult people, right? You have to affect them, you have to convince them, and you have to get the work done, right? Initial few days it might be difficult, but once people realize you well, once people realize your importance well, they'll respond to you, but you have to persist and you have to work hard for that. Another practical problem is that doing a theoretical physiotherapy, right? If you don't know what has undergone in this patient, what is the disease, you don't know what to do, right? So very important, it is not necessary that you know everything, but you have to communicate with the surgeon, communicate with the doctor, you have to know what is their expectations, right? And then you have to fulfill those expectations. So it is very important, because you are doing something else, the surgeon's expectation is something else, patient has undergone something else, you don't know. So all these dots has to be connected and individualization treatment has to be given. Right? Now another practical problem in India is hostile patients and patients' relatives, right? Our society is not so well versed with the two specialty in healthcare today. One is physiotherapy and second is psychiatrist, right? They don't consider physiotherapists as an important role, but that time will come, right? But patient don't respond, don't cooperate, there are reasons, right? Sometimes patient has a pain, they have a fear. Yesterday you have undergone a major surgery and now you are telling that you have to walk, it's difficult, right? They have anxiety that there will be a stretching on the abdomen, there will be a stretching on the stitches, and there will be some problem. Some patients are very obese, a thin lean physiotherapist is going to a patient, mobilizing an obese patient will also feel that this physiotherapist is not going to do something great. So there are a lot of practical problems which you need to work it out, right? The patient's relatives are not responding well, so you have to introduce yourself well first, very important thing, right? You have to introduce yourself as a doctor, as speak out your name, you have to create your own aura, right? Then and only then they will respond to you. You have to inform that what is your role, what is the importance of your role, and how you will affect the recovery. Then and only they will respond to you well. So this is very important, right? You go inside the room and start doing a physiotherapy or start asking the patient to do a physiotherapy, they will not respond well. You have to communicate with them, you have to talk with them, many times you have to do some kind of other talks also, right? In the past, the general practitioner, they used to talk about the family, they used to talk about the education of the sons and daughter, they used to talk about the financial aspect of the family of the patient, lot of things you have to talk, you have to make the connections, and then patient will respond to you well, right? Now sometimes you have to do a physiotherapy of such kind of gastrosurgery patient, right? There are 7-8 tubes in the patient, there is a tube from the nose, a Foley's catheter, 3-4 abdominal drains, the intercostal drain. How will you mobilize this patient? You will need a help, right? So you will need a help of the staff, you will need a help of the HK staff or nursing staff. So you have to make the connections, you have to create your aura, you have to create your charm, and that is how you become successful in your practice, right? Just getting a degree is not enough, right? Now some of the real world problem. The patient gets clothes from the hospital, some of the clothes are not fitting, right? Some of the clothes does not have a buttons, they don't have a hook, right? Patient is getting exposed, you have to take care of that also, you have to make the patient comfortable also, right? So that patient will cooperate to you. Another problem I have faced is that when you are mobilizing the patient for the first time after surgery, patient is in the bed for 24 hours, you suddenly make the patient stand, patient will feel a giddiness, right? So very important that rather than from a lying down to standing, better to sit the patient for a while and then make the patient stand. You keep the wheelchair in the backup, right? I always say my staff and the physiotherapists that whenever you are making the patient walk, if patient is fragile, if patient has a major surgery, patient is not comfortable, keep a wheelchair in the backup, otherwise patient will fall down on the floor and it will be a disaster. So these are the practical points which you may not learn in the medical college, but you have to learn while you are doing your private practice. Now see, this is the patient, see the muscle wasting. This patient has undergone 3 surgeries elsewhere, came to us, stayed in the hospital for 3.5 months, ventilator, tracheostomy, hemodialysis, and this is the patient's condition now. Now this patient has turned to these situations not because of only surgery but because of the nutrition and physiotherapy, right. So physiotherapist has an important role in recovery, but as I said, whoever is the patient, whatever is the age of the patient, whether the patient is 90-year-old or the 9-year-old, you need to know how to make the connections, and then and only then you will become a good practitioner, right. So we will come to the first slide, right. Many people feel that it is an under recognized or underappreciated field. So definitely physiotherapy has a visibility issue in India because our society is a doctor centric. They give respect to the physician and surgeon, but they don't give the same respect to the physiotherapist. Physiotherapists come into the very later part of the treatment. The surgery is done, everything is done. The ideal situation would be day before surgery, a physiotherapist consult to a patient, explain to the patient, next day surgery happens, again physiotherapist comes, give some physiotherapy, first day again give the further physiotherapy, and that is the best situation, but that is not happening in our country. That is a problem, but you have to sort it out, right. Public also has a lot of misunderstanding about the physiotherapy, that physiotherapy is just a exercise, but it is not true. It is a recovery, it is a holistic approach. So who will explain this to the society and the public? Not surgeon, not physician. The onus is on you people, right. You have to spread the awareness by different ways, and you have to improve the image of the physiotherapist in the society. It is your own job, right. Don't consider yourself as a individual physiotherapist. It is a whole profession's name which is very important, right. Behave like a consultant, work like a consultant, know the surgery, know the disease, know what is most important for this particular patient, take care that patient is getting adequate painkillers, reassure them, do a lot of kind of talks and communications, communicate well, show some compassions and execute it well, and that is how you become a successful practitioner, right. You feel underappreciated? If you see the history of the humankind or the any country, the first important thing came is a survival. Once the survival is taken care of, then people started thinking about a comfort, and once the comfort is there, then you realize that now it is a luxury which is important. Similar thing is happening to the physiotherapy and the healthcare also, right. Last 200 years people have given an importance to cardio because it is a question of life and death, right. Now cardiology is well developed, the survival is taken care of, now people have realized the importance of quality of life, the comfort. That is how now people are giving importance to the gastro specialty. What is the role of physiotherapist? It is a luxury. Having a good health is a luxury, and in India the physiotherapy is coming up in a big way. There are a lot of things which have happened, and now people have realized what is the importance of physiotherapy. Something like IPL, right. The sports physiotherapy has become famous after starting the IPL. Lot of rehabilitation centers are coming up, lot of palliative centers are coming up, lot of pain centers are coming up. Post COVID people realize the rehabilitation of the lung and the ICU. Lot of people, millions of people in the country, those who have a posture problem, don't have a core muscle strength, they have a back pain, mobile and screen, lot of cervical problems. It's a huge market, huge potential. You just need to know and find out how to tap this market, right. This is beyond training, right. You can get everything in the medical college, but if you don't do this, if you don't understand this, you may not feel that successful in your practice. So this is very important, right. Awareness is very important. People do a lot of things for marketing. You know what is the best place to market? When you are treating one patient, there are relatives, there are friends sitting there. You can aware them, you can make an awareness by doing a lot of other talks, lot of other things what you are doing, lot of other diseases what you are doing. You know, even today in my talk, I have marketed myself by showing you the video of a laparoscopic surgery or showing you the photographs of the pancreatic surgery or the liver surgery, right. This is called a non-commercial marketing, right. Your job is to make the people aware, make the people aware about the role of physiotherapist, what is important of the posture, what is important of the core muscle strength, what is important of the health, and that is how you get it needs a decade of work, right. You can't become successful immediately, right. People are underpaid. I always believe that in India people are ready to pay whatever you want, they are ready to pay. You need to find out the gap and fill it. You need to make a difference in people's lives and they will pay you whatever you want. You should realize whether you will be able to justify that payment or not, that is more important, right. So find out the gap. When I came to Vadodara, one of the surgeon in the city, and what was the first response, they said that we know everything, right, we don't need you, right, we are doing all the surgeries. That was the first response, because I was one of the first GI surgeon in the city. There was no awareness about the GI surgery. It took me almost 3-4 years to make all surgeons, physicians in the city aware what is the GI surgeon, what is the degree of GI surgeon, what is the role of what kind of surgeries I do, and it paid me dividend after 2-3 years, right. So it needs a lot of work to spread the awareness, right. So what you need, skill and knowledge, there is no option, right. Whatever you have, if you don't have a skill and knowledge, nothing is going to work. I very honestly believe that skill and knowledge and honesty, integrity is a lethal combination. If you have these two, nobody can stop you, right. The third important thing is communication. We Indians are very poor in communication, extremely poor in communication. We don't know how to talk to the friends, we don't know how to talk to the family members, we don't know how to talk to the neighbors. Few important tips in communications, and your life will be very smooth and comfortable. Find out the gap, right. GI surgery awareness was not there in the Vadodara, was a gap. GI surgery in the Vadodara, no awareness was a gap, but I find it as an opportunity. So if there is no prominent physiotherapy center or prominent physiotherapists in the city, I think it's actually an opportunity. It's an opportunity to find the gap and become a successful. You need to know some financial understanding and some of the non-commercial marketing skills, right. Lot of marketings you can do indirectly. There are ways to do it. There is a 10-year rule. If you want to become a successful in one profession, you have to spend dedicated 1 decade of time, and then and only then you can become successful, right? In a surgery, it is said that first 5 years surgeon learns how to do surgery, next 5 years they learn when to do surgery, and the last 5 years they gain the wisdom when not to do surgery, right. I try to convert this for the physiotherapist, right. The first few years you learn how to mobilize the patient, the second few years you learn that what is the patient need, and the next few years you learn how you can influence the recovery, right. The earlier you learn this part, better you are. So very important, the wisdom, right, and wisdom does not come only from the books, it needs lot of things, the reading, the communications, the exposures, meeting the people, visiting the centers, and that is how. Even after 15 years of GI surgery practice, I visit one GI center in the country every year, just to know that I have not forgotten something or I learn something new from them, right. So that is how you keep yourself exposing, and that is how you learn. So this is my last slide, right. I will just summarize that for a GI surgery, it is a chest physiotherapy, it's abdominal muscle walls physiotherapy, it's a DVT, which are very important, but I will not give you message, I will not give you that message to take home, I will give you something different, right. Learn beyond the syllabus, take ownership of your own profession. Your profession does not define your value. Many people feel that my profession is lower than the others' profession. That is not true, right. Your profession does not define your value. What value you create will define your profession. So you have to create the value of your profession And the ideal physiotherapist will be a surgeon, will be a physician, will be a philosopher, will be a friend, and will be a nutritionist. If you get combination of these two, that is how you become successful. Thank you very much. It is unfortunate that in my talk the ACs are not working or you are feeling bad, but I hope I have not taken too much time. Any questions, any suggestions, any comment would be most welcome.